pretty simple. Uh, Up till recent past, we have been believing that NAFLD is nothing. Every time we do an ultrasound, the ultrasonologist is going to report on one thing for sure, and that is fatty liver is there. Now, liver, is it something which is benign? Is it something which is just a routine finding, just like a wrinkle after the age of 50 or a gray hair after the age of 45 or 50? Is it just like that, that we're getting this report from ultrasonologist or something more than that? And the recent past, and after hearing two elegant talks by Dutta and Shahid, I think we must come to an understanding that this is something which is beginning, and we need to pick up patients right from there and not leave it to a later stage. I don't have any disclosure pertaining to this slide. And straight to my talk, how do we diagnose nephritis in Pakistan? Obviously, first thing first, we are in a country where we are heavily dependent on our clinical acumen, and obviously, the diagnosis has to be based on clinical history, examination, evaluation of body mass index, and certain common laboratories. Now, this is something which is the backbone, this is the starting point. And what do we see in the history? What do we look for in the examination? What are the important things that we are checking in the BMI and lab? There's certain non-invasive markers of steatosis, there's certain non-invasive markers of fibrosis, and then obviously NAFLD always comes in a package. You've heard from Shahid things about insulin resistance. You've heard about Shahid about increased lipogenesis. So clearly that gives us an idea that NAFLD is always coupled with certain important things like diverticulitis, heart disease, and central obesity, so many other things which come in the package, we call metabolic syndrome. So non-invasive markers of metabolic diseases, they again become an important part in the diagnostic armamentarium. And then we love to send up patients for the test, because unless we send them for the specific test, the patient is not going to feel convinced. And we are not going to be sure whether the person does have a possibility of going on from NAFLD to NASH. And for that, we have certain specific tests. And certain specific tests like ultrasonology, the good ultrasonologist can give us a good idea about the stage of NAFLD. And all those markers and the ultrasonologist criteria that we use in the staging of the liver disease in the DMC, they're applicable in the NAFLD and NASH as well. But then certain specific like elastography, transient elastography, shear wave elastography, where it gives us an idea about the amount of fat in the liver, at the same time fibrosis in the liver. And the two techniques are comparable, and they're pretty sensitive. And finally, in the advanced imaging modality like CT or MR, where MR spectroscopy or MR elastography are the fine techniques. But how commonly do we really need to go on these? Very, very occasionally, maybe in those patients where those people where we have to have a very fine decision, like in people who are potential donors for liver transplant, we need CT or we need MRE or MRS. Otherwise, in 99.9% of cases, we don't really need the advanced modality imaging like this. So on the clinical side, you have seen this cartoon. We do it almost every day. I'm sure that we're going to have a look at, we're going to have a similar replica of this at the lunchtime, at the dinner time today. And every time we go to a wedding, we can see this kind of great picture. And every time we go out with our kids as well, we see this kind of beautiful, lovely food. But this is something that comes in the clinical history, that we need to look at the dietary diary of the person, that how many times we have to go out and see public, eat this kind of food. Are you into a simple straightforward food which is free of fats, which is free of rich carbohydrates, or you are more into this kind of food? Those who come from the cities where people love to take big big chunk of weight. Obviously, this kind of scenario is quite common in the walled city. Again, in the morning, you see the people they're taking at least 3 to 4 kulchas and all this. And um till recent past, every time one starts taking their history on the diet intake, it was more like as if we are giving them body shaming. Similarly, food shaming is something, a concept that the people used to feel offended that, but doctor, why are you asking about my diet in so detail? Allah ka shukr hai, हमें सब कुछ खाने को मिलता है, and we love taking this diet, but not realizing that the problem that they have presented, maybe with the heartburn, maybe with the diabetes mellitus, maybe with the pain in the right upper quadrant, this kind of food in the history becomes very important for us, and we need to look at this. And the type of food is directly correlated with the body mass index of people. Again, one of the important clinical tools. So when we are taking history of these patients, the type of food, amount of food, and uh, their body mass index, we need to match them up with each other. The ones who love to take large amounts of meat, large sources of meat, they always tend to have greater bima. At the same time, the ones who like taking nihari, paya, biryani, and bakery products, they tend to have more aggressive bima as compared to the ones who like to take the salads, जैसे ताव साहब खाते हैं, जैसे काश मलिक साहब खाते हैं, कि सब्जियां फल ज्यादा खाएं, रोटी चावल कम खाएं, बिरयानी शरयानी दूसरों को दे दें, सब्जी दाल बगैर तड़के के ले लें. So this is something that we do. And the ones who are more into the resting kind of mode, the desk workers, the executive workers, the ones who tend to rest more, again, this becomes a very important tool in history taking, that how how many hours in a day, how many minutes in a day we spend in the gym, we spend in the park to do the exercise. And again, that correlates directly with the BMI, and that correlates directly with the metabolic syndrome parameters, and similarly development of NAFLD and NASH. And these are the important things where we need to remember that the NAFLD comes in a package. NAFLD comes with obesity, NAFLD comes with uh, more weight, NAFLD comes with increased BMI, NAFLD comes with increased eating, NAFLD comes with more rest, and ultimately the impact is that in NAFLD we have abnormal metabolism, we have inflammation, we have development of fibrosis, and that comes in coupling with heart disease and diabetes mellitus. So every patient comes with a possible diagnosis NAFLD. We have to screen them for diabetes mellitus and heart disease along with. So it's not just the NAFLD that we're dealing with in a patient, because every time in the clinical scenario a patient comes, we are not dealing with a symptom, we're not dealing with a particular disease, we are dealing with a whole patient, and the patient has to be taken in totality and not in the isolation. So what are the key elements of clinical assessment in these patients? Obviously, the key elements in a NASH are two components. One is steatosis, meaning by the amount of fat in the liver, and the other element is fibrosis in the liver, typically stiffness that we have in the liver. And steatosis can be checked through the transit elastography, the commonest tool that's available to us, although it is not available around the country, but in the major centers, yes, it is available. And on transit elastography, on shear wave elastography, it gives us an edge that we can straight away check at the liver fat, and this is called liver cap. And fibrosis, obviously, with the stiffness. And luckily, shear wave elastography machines are available in most of the major cities and not just limited to the major centers. And one can see the reports coming from the smaller cities as well at the moment. So combination of the checking of the fat, steatosis, and fibrosis gives us part the idea. And these are the detailed tools of diagnosis of NAFLD, starting from a simple test like ALT. And remember that in Southeast Asia, the ALT level for females cutoff is 19, although we can still debate on that heavily. What is the normal ALT level for males and females for our people? But there's a rough consensus that for males, any level above 25 is normal, any level above 19 in case of females is normal. So for our population, we need to bring it down to, as in contrast to the stated by European Society of Liver Disease or American Association of Study of Liver Disease, we need to focus more on the guidance coming from the Asia Pacific region or from Southeast Asia region, that we need to bring down our ALT sensitivity level down to 1925 possibly. And once ALT is high, the more the ALT is high, greater the chances that the person is likely to develop complications of NAFLD and NASH in these people. And this ALT is to be supplemented with ultrasonography. And ultrasonography is the next screening tool, followed by confirmatory tools in the form of either the blood test or in the form of specific tests like transient elastography, shear wave elastography, and other tests. The common test that we can do, just like hepatitis B and C, where every FIB-4 score and similarly ferritin levels, IgA levels are pretty sensitive in picking the right down people. So not each and every patient we need expensive modality like transient elastography machine, shear wave elastography machine, but we can do it with the simple laboratory tool as well, the lab test as well, which in any case have to be done in these patients, and they are the important monitoring tools as well. Every score is available in almost each and every hepatitis clinic. It is inculcated into the software of that hepatitis clinic, which is now available in 152 centers in Punjab, and similarly in the other provinces as hepatitis clinics are coming up, and the Punjab government is ready to share their software with the other provinces as well. And then expanded lab indices, although we're not using it regularly because proprietary tests, and their expensive tests like fibrosis and fibrometer. And then obviously direct fibrosis markers, ELF test and PII, NP test, though we're not using it in routine. So to make the thing simple, ALT, ultrasound, transient elastography, shear wave elastography available. Otherwise, EPRI and FIB-4 are good enough to give us a baseline and then monitor them further. Unfortunately, if we look at the ALT alone, in as many as 23% of patients, ALT may be normal and still the person may have a significant steatosis, but at some point in time, this ALT is going to go up. And at the same time, if we look at the literature, because there is so much of variability of ALT in the literature as a benchmarker, so it is always difficult to interpret the studies. But in majority of the patients who are suffering from NAFLD or NASH, ALT is definitely above 19 in the case of females, about 25 in case of males. So just to summarize, workup of NAFLD, we need to stratify the risk as well. There are certain SIDA patients, straightforward patients, age is young, FIB-4 is less than 1.4, and there are no features of metabolic syndrome like obesity. There's no diabetes mellitus. The chances of ischemic heart disease are minimal. Similarly, family history is not that bad in the younger age. In those cases, just like the station which is made by Dr. Shahid, that we just need to concentrate on the lifestyle intervention, monitor the patient, and repeating the non-invasive markers of fibrosis and disease progression, or maybe the sophisticated like tests like shear wave elastography or transient elastography. And then there are certain group of patients as we age, we all understand the chances of development of diabetes, development of ischemic heart disease get worse. So in the people above the age of 40 who have the features of metabolic syndrome, in these cases, maybe liver biopsy may also need to be done to convince the patient that they need a definite lifestyle modification, weight reduction, and possibly pharmacotherapies which are going to hit the market in the coming days. Although right now, although this is not my topic, Dr. Bala is going to take up on the treatment of NAFLD and NASH. But certain drugs which are available like vitamin E can be given in these patients. But bottom line is that we have to convince these patients for continuous compliance on these medicines, and that can only be done when we have a definite evidence. And finally, the people who have progressed to the cirrhotic stage, just like if there's B and C, in these patients, we have to follow the patients, plus just like any other cirrhotic, meaning by that the surveillance for hepatocellular carcinoma and complications of liver disease and complications of cirrhosis of liver need to be monitored in these patients. This pathophysiology has been dealt in detail by Dr. Shadri, so I'm not going to take much of your time, but just to emphasize once again that this is the cascade that we need to follow in the follow-up of these patients who are suffering from NAFLD NASH. It is not a simple, straightforward NAFLD NASH. It is a combination of so many things, which includes the lipid matrix abnormality, which includes carbohydrate matrix abnormality, the cell death, and then diabetes mellitus, ischemic heart disease. All these things become in package, and this package has to be dealt in these patients when we are following these patients, not just the liver alone. And in following that, again, these are two things that we have to follow. One, steatosis, the other one is fibrosis in the steatosis. Obviously, the resolution of accumulation of fat, and that is done again either with the non-invasive markers or maybe with the at times invasive markers, depending on the type of patient that we're dealing with, and fibrosis with the transient elastography, shear wave elastography, or fibrotest. This is something that we need to do. When we are monitoring these patients, every time a patient comes, weight management, weight monitoring, and emphasis on weight becomes the most important thing. And unless we are monitoring the weight, we cannot convince the patient that with this weight reduction, this is what we are going to achieve. More the weight is reduced, greater the chances that we're going to we're going to reverse the steatosis, we're going to reduce the fibrosis in a given patient who's suffering from NAFLD or NASH. And how can we do this? Again, since Dr. Badafyas is going to take up the management in detail, but just a quick slide that these are the important steps based on which we need to monitor the weight on these patients. And follow-up targets for NAFLD. You've seen this picture, a girl which was seen in dramas. It used to be quite big, and then this is recent. The message again with the advocacy groups: weight reduction, weight reduction, weight reduction, and we need to monitor as hepatologists, as